Okay, chapter 16, childbirth. Number one, you've got to know that childbirth is a normal part of life. Since there's been male and female, there's been childbirth. And it's only been in the last, oh, 70 to 100 years that we've been putting ourselves in between birthing as a medical profession. Our job is to help guide, support, and if you need to, do some resuscitation. But most of the time, we're just keeping the kid warm and we're handing them off to mom. Um, Two of the things that we need to be thinking about here are if we're going to stay and play, if we're going to we're always going to stay and play. If we're going to set up for delivery, then mom has got contractions anywhere from 30 seconds to a minute, and her intervals are about 2 to 3 minutes apart. We're going to set up for delivery. And especially if we look down in there and go, ooh, there's crowning, which is bulging in the vaginal area. That means that Junior's on his way out. Real brief review. Ovaries produce eggs. Eggs travel through the fallopian tubes. They enter the uterus, and there it sits while Junior is being created. We call those the fetus. It's encased in an amniotic sac, and it is a shock absorber. It supports and protects Junior. Here's a quick little picture that I drew for you. And as you can see here, that as Junior gets bigger, pressure on mom's bladder becomes greater, especially when in relation to that coccyx bone there. And we can see here where she's going to feel like she's got to pee a lot, and pressure on the rectum darn near killed them, will cause her to want to poop as well. So those two things, when you get close to the end, are really the key indicators that we're getting close to it. I gotta pee, I gotta poop, right? So when we talk about the stages of labor, we're talking about from start to finish. Now, first stage, is when a pregnant woman is getting ready to prepare for birth. Her body says, all right, let's go. Contractions begin regularly. Okay, there's regular contractions. The amniotic sac, the bag of waters, breaks, and it kind of flushes the vagina out and creates a lubricated channel for Junior to slide through, right? Now, as that's happening, the bloody show, as we look back here, right here at the beginning of the sacrum, or excuse me, the uterus at the bottom here, as it's going out to the vagina, there's a plug of, it's basically a great big scab that's in there. And when mom's vagina, the cervix, flattens and narrows, it rips that scab out, and along with the bag of waters breaking, lubricates the birth canal, the vagina. Now, newborn is not down there yet during these contractions, right? But we're moving into position. Junior's being squished in the right ways to kind of move into position, and the cervix is narrowing and flattening. So stage one, contractions, and end stage one with the preparation for birth. Stage two is where you have Junior being born. Now, if you see this, if you see a little head starting to pop out there, you might as well set up for delivery. Have the ambulance, if they're en route or on scene, have them get ready to deliver, because Junior's coming and there's no stopping, right? So second stage is from the point where Junior's being ready to be delivered to the point where they are delivered. Okay, so from being ready to actually delivering. Okay. The third stage is after the baby is born. Anywhere from 15 to 20 minutes later, the afterbirth is going to be coming through. That'll be the remnants of the placenta, and the umbilical cord, and all of that other stuff. And so we're going to be just stabilizing mom. She's going to have contractions after baby is born. Okay. Now, we need to ask ourselves, is there time to get her to the hospital? Where's our transport units at, and how fast can they get there? So if this is her first pregnancy, typically speaking, there's going to be time because the woman's body doesn't know how to depregnify. It's never been through it before. So if she's having contractions, and especially if there hasn't been any like mucus plugs or water, and there's going to be a fair amount of water. She's like, oh, I just peed myself or something. Yeah. If those are things have happened, we're probably getting closer to needing to set up a delivery. But if the water hasn't broken, if the bloody show hasn't happened, and she's just having contractions, we probably have enough time to get her transported to the hospital. Some of the other things, again, like I talked about before, how are those contractions? If they're less than 2 to 3 minutes apart, we really need to get set up, right? And again, like I was talking before, if she's feeling like she needs to poop, well, then we've got Junior's head pressing down on that rectum pretty hardcore. Now, please don't let her go to the bathroom. Many a child has been born into the toilet because, oh, I don't want her to be uncomfortable. I don't want her to make a mess. And Junior's born into the toilet because she pushes him right into the toilet. Not a good thing. That's a pretty crappy start to the life. So let's not do that, all right? If she does, in fact, poop, just clean her up and move on. Do I see the newborn's head? Or do I see the bulging in the vaginal area? Because that bulging in it, as soon as that starts to bulge, we're pretty much there. We're waiting on Junior. And where is our transport unit? If they're just rolling up and she's just getting started, we probably have time. However, if this is her third or fourth child and we already see, part of the hair of the Junior, it's time to catch, right? Also, things to consider when you're deciding whether you're going to set up to stay or set up to go. How far away is the hospital, right? How's the weather? Is there anything that's going to prevent us from getting in there? Is there traffic? Is there this? Is there that? All of these things are indications that we have to think of as do we stay or do we go? Now, how do I measure the contraction? All right. So when we measure contractions, it's from the start of one contraction to the start of the next. Okay. That's the interval. Okay. So 3 minutes apart. Now, the actual contraction itself, the pain part of it, is where she feels it, where it's released. And that might not be the same. It's from the start of one to the end of one is the length of the contraction. But the interval, how far apart are they, is started from the start of one to the start of the next. Okay, so if their contraction itself is lasting anywhere from 30 seconds to a minute, and the interval is anywhere from 2 to 3 minutes, we need to set up for delivery. The only real way to detect crowning is by observation. You have to take a peek. And if she's saying that I feel like I need to push, I feel like it's coming out, you're going to have to move the underwear aside and take a look. Now, obviously, if we have a female creature on hand, EMR, let her do the looking. Otherwise, we just have to do, you're professional, you're trained, you can do this. But we want to make sure that we're not loading a patient that's in active delivery into an ambulance and transporting because that's unsafe for everybody. As we get ready to deliver, we're preparing to assist. We got to help mom remember things, and we need to remember things. Number one, again, delivery is normal. People have been doing this for thousands and thousands and thousands of years. So why are we panicking? We are there just to help. I'm going to catch, I'm going to clean, just to kind of help you so you don't have to work so hard, right? And clean you off and clean the baby off. Make sure you're not making a mess of yourself. We're just here to help, right? Now, this is definitely not a sterile field. There's going to be juices squirting and there's going to be just grossness going on. But what you're going to do here is you're attempting to keep it as clean as possible. You see in the movies where they say, boil some water and get me some rags. That wasn't just to have the father something to do, although that might be some of it. But now I have something I can clean with. I don't want to put boiling water on anybody, but now I have water clean water, warm water that I can clean with. Soap and water is just fine. Make sure your hands are clean thoroughly and you have your gloves on. Make sure that you have a gown on and face mask, because again, there's going to be juices that squirt, and we don't want all that everywhere. You want the patient on a firm place with blankets and folded sheets and towels. And we want to kind of put several layers right under her hips to elevate her a little bit. It'll help. And it also, if she does make a mess, if she pees or poops, you can quickly wipe it away, move that soiled linen off to the side to keep going. Hips 2 to 4 inches with pillows and blankets. Again, that's going to help rotate the hip easier so that Junior is more in line to be pushed out. And then mom on her back with her knees bent. And sometimes she may want to pull them towards her during the contractions, and that's fine too, because that'll help, again, turn that vaginal opening so that it is more in line. Now, as mom is delivering, as things are starting to come out, blood and body fluids and everything else is going to be kind of going out there. So we got to be ready for that. Make sure that you're protected. Take a look at the skill drill slideshow just to get an idea of that. We're going to practice this in class. But make sure that you are keeping all of the methyl ethyl bad stuff, wet, sticky, and not yours, off of you, right? Because it's been percolating in there for the past 9 months. So that's going to be awesome. Smell, great smell. Some things you might want to use. There's an example here. Typically, they come in an OB kit. There's some big soaker pads, small soaker pads. I'm not real crazy about the scalpels because people don't know how to use a scalpel, but I know how to use a pair of scissors. So maybe I'll disinfect a pair of scissors and just use that. I get the bulb syringe and all kinds of pads and gloves and so forth. So just make sure you have a couple of clamps, and that's about all you really need. Here's just a list of it. There is a plastic bag in there. You can either use the packaging or the plastic bag itself that's listed, that's given in there. Because once the placenta delivers with the umbilical cord, I want to keep the portions of that for the doc to look at. Sheets and towels for mom. Again, she's going to be very sensitive to the touch. She may want to have no clothes on at all. So we might want to protect her modesty by covering up a little bit. But obviously, there can be nothing around from the waist down. That's got to be clear. Have suction for mom, suction available for Junior. Make sure you have a newborn size BVM and suction ready to go. Because you don't know if you're going to be working on a peds arrest or an infant arrest, an neonatal arrest. So we want to be prepared for all situations. Remember, when you're delivering, you don't have one patient, you have two. You have mom and the newborn. Now, we can't neglect the one for the other because the one is oh, look at the new baby. It's going to be covered in slime and sludge. Don't go, oh, I don't want to deal with that. I'm going to go take care of mom. Our primary purpose is to make sure mom is delivering, along with keeping mom safe, and we need to keep Junior safe. So that might mean you need to call in additional resources. You've got your rescue team. You've got one ambulance rolling to you. Maybe you need a second one just to back you up, a second ambulance. However, unless something's going wrong, a BLS truck can take care of this. So if you have a BLS truck coming to you, maybe you don't need an ALS, or maybe you do. It's up to you. Whatever you do, make the call quick. Now, as we're going through a normal delivery, the newborn's head should slowly emerge, right? So we're just going to put our hands there at the vaginal opening and catch. We're not going to shove our fingers in there. We're not going to try to pull mom apart to help stretch her. We're not doing anything. All we're doing is catching. We're not going to pull. We're not going to push. We're not going to shove. All we're going to do is hold that baby as it's coming out to keep it from just flopping down, okay? In a normal delivery, as the baby is being born, the head will turn to one side or the other by itself. You don't have to turn it, because otherwise you could damage Junior. But we want to be ready to suction, okay? Remember that Junior is going to be extremely slippery because not only has mom expelled her juices and baby's juice is, but baby's coated with like a little. It's almost like a paste to keep the baby um, moist for this entire process. The baby will slide out. We can just catch that as it's coming out, and we want to keep baby no higher than mama's vagina, right? We want to keep them low because if we lift them up, their blood will rush out of the body into the placenta. So we want to keep them at or below the birth canal, okay? And so here we see a little snitchum being born. Upper left goes back to our first one. So this is stage 2 of labor, and Junior's coming out. Now in B, we see here that life is not fair because Junior is looking directly at mom's butthole, right? That's how they normally come out, head down, which is good because baby is then draining. Stuff from the nose and the mouth is draining. Then you can see in C where Junior is shifted kind of to the side, and now I can do some suctioning with my bulb syringe, and I just gently guide Junior out until it's skladoosh. Now, once those shoulders are delivered, then it's going to be the whole baby's going to kind of splooge out, and when that happens, we got to be ready to catch. We don't want to drop them on the floor. Now, if we see Junior there, and there appears to be like a film between us and Junior, that's the amniotic sac, and we want to, very lightly pinch that, twist it, and it'll rupture. We would need to get that away from the baby's mouth. Also, if we see, and these things are kind of normal, if the umbilical cord is wrapped around the neck, slide it over the baby's head, okay? Slide it over the baby's head. We're never going to be yanking on that umbilical cord because we don't want it to rip free because Junior's being fed by that umbilical cord, right? So we're just going to slide it over baby's head and allow baby to be born normally, okay? Never pull on the umbilical cord. As soon as baby is out, now we have 2 patients. As soon as the umbilical cord has stopped pulsing, we're going to put some clamps on there. Now you don't have to put the clamps on, but make sure that you keep the afterbirth and everything at the same level if you're not going to cut it. But as soon as that umbilical cord touches air, it's going to start shutting down. As soon as it shuts down, as soon as there's no pulsing there, you clamp it in 2 places and cut between the clamps. And that way there's no blood everywhere. Because in that umbilical cord, there are 1 artery and 2 veins, and there's a lot of blood passing between Junior and the placenta through the umbilical cord. We're going to clear baby's mouth, and we're going to place newborn on mom's belly to keep newborn warm. Remember, we have to keep baby warm. It's actually a good idea to put baby right to breast. Even if mom's not going to breastfeed, you put mom on breast or baby on breast or on chest. You start forming that bond. They're still in sync, and there's a little bit of nourishment that comes from mom immediately before her milk comes in. Even if she's not going to breastfeed, that's one of the ways to keep Junior acclimated and start getting mom shutting down and baby starting up. Suction, we don't smack the bottom of the baby. We suction mouth first and then nose because they are obligatory mouth or nose breathers. So if I suction the nose first and then they suck in everything that's in their mouth, then they could aspirate some of that meconium stuff, and that's gross. Now, if the baby is not breathing or not breathing normally, we need to start stimulating Junior, whether we're flicking the bottom of the feet, rubbing their back, wiping them off. We're not trying to beat them up. We definitely want to stimulate their senses so that they start reacting a little bit. Because otherwise, we might have to move into resuscitative measures, which would be no fun. Again, newborn on the side. Again, when the umbilical cord stops pulsing, clamp it and cut it or tie it off with gauze. Make sure that you're noting the time of delivery. And if there's multiple births, if she says I have 2 or 3 in there, then you need to set up for the other ones to start making their appearance. Because the more there are in there, the smaller they are. And remember, the first one has already made the way easy for the next ones. Okay, so we've got to be very careful there. Make sure that you note the time, and if there are multiples coming out, you're going to have to somehow denote which one came first without writing on the child. So, a string or a band or something around them. Hey, this one was out first at this time. This one was out at this time. Now, if we have a normal delivery and EMS is en route and so forth, you can leave the umbilical cord uncut and attached. Um, if you find that junior and umbilical cord are already out by the time you get there. We never pull on the umbilical cord out of mama, but I have never, ever, in all my years, witnessed leaving the placenta attached, even in the first responder setting. However, if you feel uncomfortable tying it off, make sure that the uh, placenta is at least at the level of junior, but probably a little bit higher. Okay. Make sure it's in a plastic bag because you're still going to transport it with junior. Now, after that, mom normally stops bleeding after the placenta is delivered because she's starting to shut down. But if she doesn't, we massage the top of her belly, the uterus, and just above one hand above the pubic bone, and just really kind of grind in there a little bit, and it tells the body, hey, I can close down. But really, she shouldn't be bleeding much after 3 to 5 minutes. If she is, we need to note that and really start getting ready for transport. Um, Remember, she's just done the equivalent of a bazillion sit-ups, crunches, whatever you want to call. She's not going to be pleased with you doing that, but it's going to have to be done to help her out. Obviously, after both mom is cared for and newborn is out, we're going to just evaluate them both. We're going to keep doing reassessments on both of them, right? And we're going to check in on them every about 3 to 5 minutes. We want to make sure that she's not bleeding, right? Now, mom loses about a half a liter of blood during delivery. Well, if she's a smaller person, that's a significant amount of blood. In fact, a half a liter causes most people to go into light signs and symptoms of shock. So if you have somebody that has bled more than that, you got to be very careful about, hey, is she moving into shock? Am I going to lose her or that kind of thing? Continue to massage that uterus. Make sure it starts shutting down. Clean mom up as best as possible with moist towels or cloths. And if she's thirsty, little sips of water, because again, she has lost some blood, and so she's going to be feeling a little dehydrated. So give her a little bit of fluids there. Treat for shock. A little bit of oxygen never hurt anything. Nasal cannula would be good in this situation if she's not showing any major signs and symptoms here. Now, if we have to move into CPR with newborns, uh, we have to do that in the first minute of life or first minute after delivery. Because if junior's not doing their own thing, we have to do it for them. Now, we'll work on that in the skill drills. I'll let you look that through. But during CPR, if their heart rate is below 60, we need to start CPR to get that heart rate up, to get the respiratory rate up. Otherwise, they're not going to fare well. Some of the complications, actually, there's quite a few complications. We couldn't possibly cover them all, but we'll cover some of them. The first thing would be if you have a female that's complaining of abdominal pain, either on left or right side, and she hasn't had a period in a little while. It could be that she was impregnated, that the egg was fertilized before it got to the uterus, somewhere along the fallopian tube. If that's the case, as the embryo starts to grow, it could rupture the fallopian tube, causing mom to bleed to death. Okay, there's really no hope for the embryo because it's just not viable in that location. Acute abdominal pain, internal bleeding, shock. We need to get this person out of there and to the hospital. Now, later on in the pregnancy, maybe she's been 1, 2, 3, 4 months. Uh, a miscarriage is also called a spontaneous abortion, and it's when mom's body delivers an incomplete or underdeveloped fetus. A a baby that is incompatible with living. They can't live on their own for anything. They don't have developed thises or that's. If a miscarriage occurs, um, put everything that passes out of mom into a plastic bag so that it can be evaluated to make sure that mom's not having any pieces left inside of her, which would cause her to get infections. Treat mom for bleeding and shock, but also make sure that there's, you're doing some mental well-being for mom too, because this can be very trying for her. Make sure you get some prompt transport coming in on that. Vaginal bleeding during pregnancy is often the first sign of miscarriage. Please get onto a patient assessment. Please transport them as soon as humanly possible. Good sense of vitals, and again, emotional support if she does in fact miscarry. Now, miscarriages and spontaneous abortions are different from premature birth. These are kids that weigh less than 5 pounds or delivered before 36 weeks. Now, 36 to 40 weeks is full term, considered full term. So before 36 weeks, you're stating the test that something's not fully developed yet, and so you're going to have some issues that you might have to provide supportive care for. And the smaller they are, the harder it will be. Remember that premature newborns are smaller, thinner, and typically redder than full-term babies, newborns, because their skin's not fully developed yet. They will lose heat quickly, so we need to make sure that we've got that junior wrapped up, and that we're supporting them with as much care as possible. But they got to be very gentle with keeping them warm, because if we make them too warm, we can burn them, we can cook them, and we don't want to do that either. We talked about it briefly during normal delivery. If you see an unbroken bag of waters, you're just going to have to push that away, kind of pinch it and twist it until it ruptures. But if it's unruptured and you rupture it, remember it's a bag of waters. There's juices coming out there. Don't grab newborn and pinch him or her. Okay. Make sure also that you are suctioning baby as they're coming out, so they can help get some good air going in and out there. Okay. Now, if I look down there, and she says, I got to be, I'm delivering, I know I am. You look down there, you see a cord hanging out. This could cause complications because that's the baby's lifeline, and it's being squished by the head. We don't want mom to deliver in this instance. We're not going to shove it back in there either. So we're going to put her on her side, and we're going to put her on her side, and we're going to make sure her hips are raised so that it kind of, using gravity against her, we're going to have her pant through her contractions, and we're going to keep that cord covered and moist as much as humanly possible, because again, when the cord hits the air, it says to itself, my job is over, I can start shutting down. If that happens, then Junior's toast because they're not outside yet. O2, really want to get moving to transport, and if mom's having a hard time there, maybe we put her down in the head down, rear end up, a kneeling position, so that her belly gravity is pulling her back the other way. We're not going to shove anything, but we definitely want to take the pressure off the cord as much as humanly possible. Some other complications you may run into, but these will be the ones that don't have prenatal care. Maybe they don't even know that they're pregnant. But a breech presentation. A breech is where the rear end comes out first, rather than the head. They come out butt first. You look down there and you see a smile that's not on their face, you know you got a problem. So you're going to want to make sure that you're supporting mom as much as possible. If they do deliver, because they're very bendy, you just support them and try to allow for Junior to be born just catching. And remember, you're going to have the body rather than the head, so you're going to make sure you don't twist the head off, all right? Now, if the head does not deliver, you're going to have to put your hands up the mom's hoo-ha and create a cavern between mom's meat of her vaginal wall and the baby's face. Some blow-by oxygen would be very good there, because if we don't do that, Junior's going to suffocate and die. Okay, so we got to make sure that we're working on it. But these are so rare, so rare. Also on the rarity is maybe you look down there and you see somebody's hand or foot waving at you, right? That's a limb presentation, and typically speaking, may or may not deliver that way. Just again, be supportive, excuse me, and call for additional manpower and additional transport units. Now, sometimes newborn dies before it even is born. Um, Typically, during these deliveries, you'll immediately know something's wrong because it's going to stink, right? And it might come out in pieces because what has gone is the baby starting to decompose in mom. Make sure you keep as many pieces as possible, but make sure that you're taking care of mom because she's going to have a real hard time with this. Okay, so do not start CPR on little ones that have obviously already been dead and they're starting to decompose. Again, we talked about multiple births. That's kind of a complication. As far as complications go, if she's full term, it's just going to be a quicker delivery, right? But it's going to be deliver one, you're ready for the second one, deliver the second one. So that's going to have. So if you have a multiple birth, you're going to need to have more hands there in the clean field. That means you're going to have at least one more ambulance, maybe two, depending on how many kids are coming out. And remember that you need to note who's coming out at what time. Also, remember after bleeding, she could lose some more than her 500 mLs of blood at half a liter. If that's the case, she's going to be going into shock, and we're going to have to work on supportive care there. Now, we never put anything in the hoo-ha after she's done expelling critters, those little lovely parasites. But we do want there's a great big industrial sanitary napkin in the OB-GYN kit. Have that put into place, put her legs together, put her in the shock, treating for shock, where it's laying supine, maybe elevate the legs a little bit, give her some oxygen, keep her warm, and get her going to the hospital with however many kids that she's got. Okay. Again, even if mom's not going to wind up breastfeeding, it absolutely helps the bleeding to stop. So if you were to put a baby to breast, that action is a physiological response that sends hormones out to the uterus that says, you can close down now. There is nobody here, right? And so then we have the massaging that go on too. Also, there might be some open wounds on mom's vaginal area. When baby delivers explosively from the vagina to the anus, it could rip, right? And so if it rips or tears, we might have to treat an open wound in the vaginal area, in the genital area. So be mindful of that and be as kind and compassionate and as non-invasive as humanly possible. Now, obviously, during any kinds of trauma, a pregnant female should go get seen by a doc because this might be the instance where the meconium staining happens because the baby's under stress, right? Or the baby poops into its own fluids. And that'll be stinky too. So when you're delivering, there'll be like a green tint to the fluid, and it'll stink like poop. Because babies don't typically poop into their own fluids. Okay. We need to get these people from collisions or traumas to a OB-GYN at the hospitals and give them a look. Especially if they're showing signs and symptoms of shock. Because in shock, remember, mom or a normal human being shunts resources away from the limbs and digestive things and so forth to keep the primary body alive. So when mom is in distress, Junior is starting to have problems that way as well. Now, if we have a pregnant woman that is being transported, we need to make sure we lay her on her left side rather than on her back. If we lay her on her back, the weight of Junior will press on her vena cava, her big vein that goes back from the legs to the heart, and it will cause shock symptoms. We call that supine hypotensive syndrome. Big word to say, Baby's laying on the vein, causing mom to have signs and symptoms of shock. Lay mom on her left side, and things will be good. Now, in the rare case where there is a pregnant woman that is killed in a trauma, you are not allowed to do anything to get that baby out of her. However, you can do CPR to keep the body of mom viable enough that perhaps a hospital can get baby out, right, during emergency C-section. You don't have that capability. EMTs don't have, paramedics don't have that capability. But we can get them to the hospital if we can keep mom alive, or the body alive. She might be brain dead, but we might be able to save the baby. So if it looks like she's pregnant, or if you see the belly moving and she expires, then you need to do your best to keep that body sort of viable. Okay? These are if these other complications are rare, this is like the super rares. Okay. All right, so we're at the end of chapter 16 now. A couple of slides of summary just to remind you of some of the key things. Remember, how soon are we going to be delivering? 30 seconds to a minute of contraction, and the contractions are 2 to 3 minutes apart. We need to get ready to go. Other things that we need to think about is how far away, are we staying and playing, or are we making sure that someone's loading and going? Stage 1 of labor occurs when the contractions begin, waters break, bloody show occurs, and the baby's head gets into the downward position to come out. Stage 2 starts from that point where baby's head is ready to come out, baby crowns and delivers. We assist during that time frame. And then stage 3 is after baby has been born, all the way through everything else, the afterbirth being born. We want standard precautions while assisting with delivery. There's going to be lots of fluids, lots of juices and disgusting grossness that is not yours, so make sure that you don't take any home to your beloveds. Remember that after delivery, you have 2 patients at minimum. So make sure that you're prepared for 2 patients. If the baby obviously does not breathe on its own in the first minute, you need to proceed with CPR. And although most pregnancies and births are uneventful, you should be aware of all of the possible complications, the ramifications, and what do you do about them. Okay? Again, this is chapter 16.